So, good evening, everyone. I'm Roger Mosey, the Master of Selwyn. You are very welcome if you're joining us here in the Quarry Whitehouse Auditorium, and also everyone joining online, you are equally welcome. Now, here at Selwyn, we pride ourselves on tackling the big issues of the day. So, this term already we've had global instability with Mark Urban, and then the discussion on the US presidential election. And tonight very much fits within that, and arguably something even bigger, because it's about a health emergency that could affect us all, already visible, and a looming crisis potentially affecting humans, the food chain, and many of our current assumptions about healthcare. So we have with us the top guest, Dame Sally Davies, who is the UK Special Envoy on Antimicrobial Resistance. She's a former Chief Medical Officer, and she's also the Master of Trinity College. So we'll talk to Sally in about 6 minutes from now, because what we're going to do first is show you a film. Now, if you're watching online live, you'll be able to see this. If you're watching on demand, you'll be able to catch up with it through a link we'll put on the website. So if we could see the film, please. Sally, welcome. We have in this room a number of people who are medical professors and other kinds of professors. So tonight I'm going to interview you for a shorter time because I think the audience should ask you the questions, and we will have questions from the audience pretty soon. Can I ask you though, having seen that film, what's your priority now as the UK Special Envoy? Is it about awareness, or is there action we can now be taking that you're advocating?
That's the problem. Like so many things, there's no silver bullet. So we have to do everything. And we do need to engage people and spread awareness. So we can talk about the musical we took to off-Broadway for the month of September and other things we've been doing from the UK. We need new medication, new drugs, new interventions. And we can talk about the market failure and the pull incentive we've put in and the work we do with G7. We need to have better diagnostics because blood cultures, which is the gold standard, has a high false sensitivity and specificity rate and takes days. So we need better ones. We need to use what we've got better. In both humans and animals, the food chain uses over 70% of the antibiotics. So I can bore for Britain on all the things we need to do. And one of the ones I'm putting a lot of effort into at the moment, backed by the government, is the setting up. It was agreed at the UN General Assembly this year in September of a new independent science panel. So like the IPCC for climate, to have a panel that looks at the evidence and proclaims it and actually helps countries by sharing the evidence, but also begins to get a drumbeat of this matters and look at what the evidence is. So we're trying to get that going at the moment.
If you're back in your previous role of Chief Medical Officer, or if you're now in government, an incoming new government, how do you calibrate this crisis against the others? Because we know, for instance, for the COVID epidemic, we were not prepared. There's equally, you talk about the obesity crisis. There are all sorts of health crises looming. Where does this rate within it? Is it just one of the things to do, or is it an overarching big priority?
I think it's pretty overarching because if we don't have effective anti-infectives, we've lost our health security. 1 in 4 cancer patients gets a serious infection. Many are actually dying, though people don't know it, because of resistant infections. So we've got health security and the added cost when resistance is present. It, as a rule of thumb, doubles the length of time in hospital, doubles the cost and doubles the mortality. But it's also our food security. At the moment, antibiotics are used out with the European Union and Britain quite often for growth promotion or because it's cheaper than infection prevention and control, called biosecurity. But, resistant bugs are going up and up. And so our food security is at risk. We're beginning to recognise the impact on the environment, both as a host of antimicrobial resistance. For instance, you have the plasticine, you get biofilms on them. Well, guess what? Biofilms of antimicrobial resistant bacteria love being on plastics floating around the oceans, for instance, let alone the way that manufacturing happens, and the effluent is usually laced with large doses of precursors or antibiotics. So we've got environmental security, and then when all of those are threatened, your economic security is threatened. And I would argue that anti-infectives, it'll be interesting to see whether the medical profession in this room agree with me, are actually infrastructure for the whole of our modern health systems and food systems. Without them, it will crumble.
We have a range of scientists. I see a little cluster of chemists even as well. As a complete non-scientist, if it's been 30 years since we last found a new antibiotic, why is there confidence that we can find more?
So it's 30 years, the late 80s, since we had a new class of antibiotics that have come into routine clinical use. There have been some new antibiotics, some not very different from previous ones, some that look really hopeful. But we have a market failure. So the model at the moment seems to be university spin-outs and SMEs work and find a target and a potential drug and may even take it to phase 1. And then what you'd expect if it was any other area is a big pharma would say, oh, that looks hopeful, right, I'll pay a lot of money and buy it up. And they'd take it through phase 2 and 3 clinical trials, get it licensed and then put it in the market. Unfortunately, most antibiotics are generics, they're off patent, so they're terribly cheap. So we're not used to paying much for our antibiotics. And we don't seem to have systems across the world that recognises that you should pay as much for an antibiotic that can save a 23-year-old in the workforce as we do for a cancer drug that saves a 50-year-old who may or may not be in the workforce. We just haven't got it right.
Another question based on a film from a non-scientist, non-medic. As an individual, should we be avoiding antibiotics?
Yes, unless you really need them.
Unless you really need them.
I mean, people say to me, so you don't want me to take antibiotics? And I say, I want them to be available for when you really need them. And even some bacterial infections now, I haven't seen patients since 2006, so I'm not the one to ask. But even some bacterial infections, if you've got normal immunity, you do not need antibiotics.
And is the perception that patients expect and doctors too readily give in to the fact people go along to the doctor wanting antibiotics?
That's the perception across the world. Many patients would say doctors are hiding behind that, and so there's clearly truth on both sides.
Okay. I'm going to go to questions from the audience very soon, but just before I do, I want to touch on your previous role, Chief Medical Officer. And you were very distinguished in that role by most accounts. But there were people who said when you left, good riddance to the nanny in chief. Is that what you get from being a public official these days?
Yes, I was honoured to be Chief Medical Officer for nearly a decade, and it was absolutely fascinating from the political side, but actually to be able to influence things. Not always as much as I wanted. But what they don't tell you is the public derision that can happen if they don't like what you say, nor do they tell you you're never off the hook. So I was at the Novichok inquiry last week and had 3.5 hours that were really tough of questioning. I've been at the COVID inquiry, the infected blood inquiry, and here I am minding my own business in Cambridge. And I do think Nanny is very sexist. And I remember in the last week of my time, I was on the Today programme and I told you who it was.
Nick Robinson.
Yeah, Nick Robinson said something about Nanny, and I absolutely laid into him. It's sexist. Are they calling Chris Whitty Nanny? No. And he and I want the same things. But maybe the Tories like nannies. Maybe they want spanking.
Are these jobs doable? Because, of course, Novichok came as something which, I mean, you wouldn't really have had that on the risk register, I guess. Maybe you should, maybe it was. But also a pandemic where it looks like we made preparations for the wrong pandemic, and infected blood, which was, again, a terrible scandal, but let's hope a one-off or be a protracted one-off. How can you as Chief Medical Officer be across all those range of eventualities? Is it a doable job?
It's only doable if people support you, experts, and you're prepared to listen. But I was supported by lots of people who knew what they were doing and would come and tell me what to do, and I'm a good listener and challenger, and I managed, yeah.
Right, questions from the audience, please.
It's a team sport, I think is what I'm saying.
We have Mel with the yellow box and Tissat with the red one, so we can throw this around as we go. So who wants to go first? Yeah. Is that an early Christmas jumper? All right. Okay.
When you say that antibiotic use is sort of structural, within the medical profession, do you think perhaps there's a perception that's more structural than it really actually sort of needs to be? Because I think we had a lecture the other day saying that within agriculture since 2014, the levels of antibiotic use have tumbled hugely because of concerns of antibiotic resistance. So do you think some more stuff medically you could be doing to reduce the use?
So the data for animal use is it's gone down in this country voluntarily by 59%. That tells you they were overusing antibiotics, and they're now being more thoughtful, and they're probably doing a bit better hand washing and biosecurity where it's fairly intensive or intensive. They may be using vaccines. Purdue Poultry, one of the top 4 in the States, have got rid of antibiotics out of their poultry farms, which are very intensive because they vaccinate, I love it, robotic vaccination of eggs, and then they hatch and they spray vaccine over them, which is absorbed through the eyes or gobbled up through the beaks. And they don't use antibiotics. So that explains the animals. We still want antibiotics for sick animals, and you may have to treat some animals around a sick animal. In humans, we have, as a nation, an objective to drop our use. I can never remember numbers, so I can't remember by how much, and we haven't succeeded. What we have done is stayed fairly steady. And I don't think that's too bad because, and there'll be people here who know about this much more than me, case mix has got more complex, in other words, and demographics have changed. We're getting more elderly people in hospital who have less good immune systems, and we're getting more complex cases in hospital. So despite the increasing need almost, they're managing to stay pretty stable on antibiotic use, but we're not where we set out to be, and I think it's proving very difficult. But I was arguing that you can't have a modern medical health system, whether it's for humans or animals, without anti-infectives. And I don't just mean antibiotics. They treat bacteria. I mean antifungals. A lot of leukemia patients die from fungal infections, increasing resistance there. Antivirals, HIV patients, when they present now, so their first time they're diagnosed, I think nearly 20% are resistant to first-line drugs. So it's across all infective organisms. And so that's why I think their infrastructure, just as beds and sinks and clean water and X-ray machines are.
Can I ask, in veterinary training, is there a sense of being aware of antimicrobial resistance, and is something you factor in, is something you talk about?
Yeah, I mean, I think we've had maybe 4 or 5 lectures just this term on sort of antimicrobial resistance.
Oof. Our vet school is strong on AMR, but that's good. I wish they were all as good as that.
Okay, more questions, please. Luke, in the dark blue shirt. Yeah.
So I work in intensive care, and I know we can be quite bad at being liberal with antibiotics sometimes. And I guess my question is there anything in particular that clinicians working in secondary care can do to try and stop the growth of antimicrobial resistance? And I guess...
Well, I'm always careful to recognise that you may know more than me, but for everyone else rather than you, yes, clearly try and prevent infections, hand washing, and where necessary, masks, gowns, whatever. But then one of the reasons I battle about this is because I want you to be able to use, when you're concerned about a patient, a broad-spectrum antibiotic while you get the diagnosis, and then change as soon as you can, we hope within 24 to 48 hours, to the narrow spectrum appropriate antibiotic. So I'm not going to stand up and say you shouldn't use them, far from it, and you will know when you need to use them. Can we improve diagnostics? I was thrilled to see the other day that the UK Health Security Agency is rolling out with Oxford Nanopore genomic testing for respiratory pathogens across a lot of labs. So I'm hoping Adam Brooks is one and you'll have access to that. That's a technology where you do the genome of the bacteria, and instead of doing it in the standard Cambridge technology way, where you chop the genome in bits and look at what the sequence is and then try and put it back together like a jigsaw, it's what's called a long read, so it reads the whole bacterial genome in one go. And now we have maps of if you've got that mutation there, you're going to be resistant to this drug and that drug. So, and you can get an answer in 6 to 8 hours. So, I mean, that'll change your respiratory pathogens, which for all your ventilator patients and many others is going to be very important. So, progress.
Thank you.
Happy with that answer?
Very.
Good. Can I just ask a question again as an utter non-specialist? The people who are dying at the moment, when people talk about catching a superbug, what does that mean?
Well, it means they've caught, generally we're talking about bacteria, a bacteria that does not respond to antibiotics. So first line, probably second line, and if they're dying of it, third line if they have them available. Remember that many parts of the world don't have them available. In this country, I used to know how many. Is it 35,000 die a year of AMR? Across the world, it's 1.2 million die of AMR, but 5 million every year die with AMR. So if you've got cancer and you've got an infection, you may well be dying of AMR, but the death certificate often says just cancer. The good news on that is England and Wales brought in a new system in April, of medical examiners. So all our death certificates in England and Wales are being examined to check that they're correct. And if they find infection, then they're going to look back, the medical examiners, I don't know whether you knew this, and see whether there's any resistance. So we will have good data. And the medical examiners have all been trained by the Royal College of Pathologists. So this is quite exciting what we're going to learn.
Okay. More questions, please. Professor Keeler, who's head of chemistry for universities.
I was interested in your description of the financial problem that, going that stage from promising research to a drug on the market. Can you see a way out of this? Because I think at the moment this is probably the major block at getting new things to market. Is there an alternative method?
Yes, and we in Britain lead the way, of course. So what it is what's called a de-linked mechanism, and we've developed it here, and we're now trying to persuade everyone in G7 to do it. So we started with a pilot of 2 drugs, 2 new antibiotics that looked really worthwhile, and they were assessed with a normal health technology assessment. In other words, they were looked at from the perspective of the patient. How many high-quality extra years do you get? QALYs and DALYs, disability-adjusted life years, quality-adjusted life years, and death. What do you get? But then the nation did, but it was actually the NHS executive, NICE, and York University Health Economics Department, who did a much more societal assessment of what's the value of this drug to society if you think about it as a fire extinguisher on the shelf of a pharmacy, being able to stop that resistant bug in its tracks, that it's not going to mean you have to close a ward, a side room, a ward. You're not going to have to isolate the family. You're not going to have it spreading in society. And so we got a kind of societal value. All of this was done very openly in discussion with industry and academic experts and people on all of this, and then that came up with a value for that drug. We then look at our share of GDP of the G7 to see what part we should be paying, divide it over 10 years, and we set contracts that they were happy with, initially for 3 years, but extendable up to 10 years. So they get paid each year while we don't need to use the drug unless we really need it. Because, of course, the minute you use it, you drive resistance. But you want to be able to use it if you need it. But they get a stable income, because the way drugs are normally funded is either they're very expensive for cancer, so you get a big profit and a payback, or it's something like high blood pressure or diabetes. You make a tiny profit, but you get it every day of that person's life forever and ever. And what we have is a problem that we don't want people to use antibiotics and anti-infectives because that drives resistance. So they can't make a pile them high and let's get a bit of profit. So we've been working with the G7. Luckily, Jeremy Hunt spent 4 years as health minister with me and then became chancellor, so he was very supportive. Italy has just announced a pull mechanism, not a subscription, but they have a different health system, and they say they're going to put their fair share in. Germany has one they say is a pull mechanism. It isn't. The Americans have something called the Pasteur Act on the Hill, bipartisan, modelled on our subscription system. I think it's got stuck and I think it's going to get lost. Let's hope that Trump, being a germaphobe, brings it back. Let me think. The Japanese are doing a pilot. It's piddling. I've told their Minister of Health it's not good enough, but at least they're starting. The French are scared that then they'll have to do special things for cancer, so they're not even on the starting blocks, but on we go, trying. We will have the presidency of the G7 again in 2028, the centenary of Fleming discovering penicillin. So I've just today started geeing up government saying, come on, let's get going with the G7 and really say, can we crack it for 2028?
How difficult is it to make those international corporations work? I mean, it sounds like it involves lots of banging of heads.
Yes, it's not easy because, you know, even if people can see it intellectually, what's in it for them? I mean, what was in it for Britain? Oh, they were leadings, and I persuaded them they needed it. But you have to find a way to get them. It's not even vast amounts of money. This is cheap and it pays off. Money into sorting out AMR, you get a return on investment of 1 to 24. I mean, it's nuts that people won't do it. So I'm clearly not persuasive enough.
The now Pro-Vice Chancellor, but formerly head of the School of Biological Sciences, Professor Philpott.
So, does Robert F. Kennedy believe in antibiotics? And do you have any idea whether this new administration will be good, bad, or hopefully at least indifferent to our efforts?
I can't believe he doesn't take antibiotics. I mean, that would be denial above all, wouldn't it? Even if he doesn't take vaccines. I did see something from an autism society saying, this is dreadful. We do not believe we are autistic because of vaccines. So there's two sides to it, and I thought that was an interesting one. Where's the new administration going to be? Well, the present one is scared witless of where they're going to be on this sort of thing. I mean, they've been voicing it to me. I will go in assuming they're going to be helpful because it's the only way you get cooperation, and we'll see where we get. I've no idea. But I will assume they're going to help until they prove otherwise. And even then I'll keep going because you can't give up.
I saw hands over there as well, right behind you, Melanie. There.
Hi. With the use of AI and sort of drug discovery much quicker with technology. How come it's so hard to discover a new antibiotic? And then second question is, a bit like COVID and flu, where you react to different variants and mutations, do we think that we can react much more quickly to bacterial resistance with that sort of new technology?
So most antibiotics are, and we've got a chemist who will know much more than I do, head of chemistry even, so he mustn't he? Are complex molecules, and they've come from natural sources, and small molecules don't seem to work. So there was a belief when I started making a lot of noise about this some 12, 13 years ago that the science was too difficult, we couldn't do it. But actually there have been a number of advances. One is at finding a new way to grow bugs that are in soil. And then you start to find things. There's one wonderful department in Germany that looks at insects, because insects, like us, live with all these bacteria, and they make antibacterials. So we're finding new ways to look at the natural world, as well as understanding bacteria better. I mean, what I haven't mentioned, and I think is an important bit, is it's not just that a bacteria has a natural mutation and, there's an antibiotic there, it gives it a survival advantage, so, hey, it passes it down. They can pass the DNA, because it's often plasmids or other bits of DNA, to their friends, their cousins, and then to their children. They can pass them from one type of bacterial species to another type of bacterial species. So these mutated AMR genes kind of move around rather well. There's nice studies done by Exeter University of the sea near there, because their students go surfing, just looking at the number of AMR genes in the E. coli in the water. E. coli going up and up. Well, with our sewage systems in this country, is this a surprise? I'm allowed to say what I want now, I'm no longer CMO. But also the AMR genes are going up. So, I think it's more complex than lots of people realise. Back to AI. So there is, and I met him recently, he's called Jim something, can't remember, this professor at Boston who's used AI to screen potential molecules to be used as anti-infectives, and looks as if he's found a couple on the first pass. So clearly we may find new ones, I think we will, through AI. We may be able to use them better using AI. And we had a really interesting meeting in New York with top scientists from Google and Microsoft. And what they were also talking about doing, which I thought sounded quite exciting, was being able to see how bugs evolve and seeing whether they could predict where resistance would come, and then start looking for treatments that would stop that happening. So, and they thought AI would play a role in understanding evolution and predicting. So I think there will be lots of different ways.
Okay, yes, a fellow of the Royal Society there. It's a class audience tonight.
It is. I thought I was talking to students. I didn't know I was having the works.
It's all these sewing alumni, you see.
That's actually the only reason why I don't really want to ask a question, actually. I'm not a medic. I'm going to ask a very, very naive question, an odd question, which is that I'm surprised that antimicrobial resistance is not increasing more rapidly. So I get that I get that there's huge incidences of this, but it doesn't, you would think that once it was released, it would actually spread very fast, and it doesn't seem to. Am I wrong about that?
So I think it's a combination of, it can spread if you've got poor infection control. So if you look in low-income countries, drug-resistant cholera and typhoid and things, they spread like wildfire through the water. On the other hand, generally the mutations, I'm told, give a survival disadvantage to the bug. So if you go to India, you'll come back, or I come back anyway, I believe, with my microbiome full of bugs which have got AMR. But 6 to 9 months later, if you look, they'll have gone away. I will have, the normal versions will have triumphed because of that survival disadvantage. So I think there's something about nature, and then there's something about if you live in a clean environment like us, infections are not promulgated as much. Does anyone want to disagree and tell me there's a better answer?
I suppose my question from that would be, could there then be a sudden breakdown? So that's what happens at the moment, but it could change?
Yeah.
Okay, behind in the... I can't read the...
I mean, I think this is truly scary. Let me be clear.
So could I ask, kind of off the back of that, if when a bacterium is kind of not in an environment where it's likely to be exposed to an antibiotic, that kind of resistance gene is selected against. So does that mean that, you know, if we just like stop using penicillin for a little bit, that kind of gene will, you know, that like resistance is likely to go down, and then we can just start using penicillin again?
It does.
Yeah.
They've shown if we cycle antibiotics, the resistance goes down to undetectable, but it will then come back. But it can take some time to come back. But then the other part to say is they found, you know, up the Amazon where people haven't had antibiotics, resistant genes, so they've happened by chance, and they just are tested on a day where the bugs got it.
Thanks very much.
More questions. Right in the middle with the black and white T-shirt.
Thank you. It's just a follow-up. I know that the UK is leading the support with low middle income countries. I work with the management agent that is coordinating that. I'm just curious because part of what we're trying to do with the low and middle income country is look at the One Health approach and see how that nexus is working to tackle AMR. I'm just curious about how that is happening in the UK, because you did talk about it a bit, but I'm just wondering if the focus here is just on the human health aspect of stuff, or if there is that nexus around One Health.
In this country we really do link up One Health. So the data is generally collected separately, but then there are various reports that put it all together. And there was a big £22 million project funded across government looking at the DNA and joining all of that up. So I think we join up quite well. But what I think you're also talking about is our Fleming Fund, and I persuaded George Osborne to give me the money. We've spent 280 million so far and more going, where we support, at the moment, 25 countries to develop their laboratories so that they can do surveillance, so they know the problem, which can then guide them on how to manage patients, but also allows them to think what should they be buying and doing. We've got some more programmes that are going to start. There was a promise from the former government in mid-May, and we're waiting for the spending review to confirm whether the money's still there, to work in 3 African countries to improve access to standard oral drugs, because when you get to the community, a lot of people in poor countries can't get it, so we're hoping that'll come through. We're looking at a big programme to improve labs in the Caribbean. We've got quite a lot of things going on around the world, yeah.
When you talk about the way you're getting this action, you yourself can't pull any levers, right? You have to persuade other people to do that. So that must be the challenge.
Yes, and it's got to be done in every country. And it needs political action, because you've got to have the will to make change and to fund the change. So while I would argue it's an investment, and we've got quite a lot of data now on that, you know, having healthy people and healthy food chain and everything, you've got to somehow get people to understand that and then have enough money to make it all happen.
And you've got a Prime Minister who's worrying about the economy and about Ukraine and about everything else. So getting it up the agenda must be a key part of your job.
Oh, yeah. Yes, here and in other countries. Yes. But this government, I mean, it's apolitical. This government's very supportive. I've been told to turbocharge my work.
Okay. Charlotte's a first-year medical student, so...
Is there any general consensus on what the biggest culprit is in terms of the source of these resistant pathogens? So is it agriculture, or is it in hospitals or the community, or does it depend on the pathogen? And has this changed over time, or has it been relatively consistent?
What an amazingly good question, and no one really knows the answer. And I end up at meetings where lots of human health people, doctors and nurses, blame the agriculture sector. But actually, most of the bugs that give humans problems are in the health system, and we have made them worse through the health system, misuse and everything. Yes, you want to know that in Denmark they've got so much MRSA in their pigs that the farmers, their wives, the farmer might be a woman, of course, but the women from the farms, if they're pregnant and go in for delivery to hospital, go into special rooms and can only stay 24 hours because of the risk to the rest of the hospital. They have to, if they go into hospital for any other reason, the emergency room, say, I come from a pig farm, and they're put in a separate room. So, it's got that bad in Denmark, and it's quite bad in some other places.
Okay, I'll go to people that haven't. Professor Dix here, so
Thank you.
specialises usually in wasps and insects. But
Yeah, so I'm a conservation biologist, and I'm thinking about other global problems. So for me, this sounds like a very global problem. I'd really like to hear your international perspective on where in the world the practices are worst, and then it's also a behaviour change problem, right? So what do you do about this? There's the side of it where you're trying to develop new antibiotics and get the technology moving again. But there's also the side about overuse of antibiotics. How do you see the balance between voluntary best practice and regulation in that space?
Well, clearly I work with governments because I'm aiming for regulation, but I absolutely get we need behaviour change, and I'm really excited that we've started in London a big initiative called the Fleming Initiative that's going to do quite a lot of work working at the moment with YouTube health influencers. So we're trying different ways in. I mentioned Lifeline, the musical that we've had for 4 weeks off Broadway. And that's amazing because it's the story of Fleming's life and discovering penicillin entwined with a real-life story of a young couple who met at university, parted, she became a doctor, he comes back into hospital where she seems to be looking after him, and remember this is true, age 29, the operation for his bowel cancer was a success and he dies of AMR, and it's true. In 2020 I set up a charity called the Trinity Challenge, and I've just this year run a challenge for how can we get better data, One Health in low and middle income countries to prevent AMR. And there's a very nice Vietnamese winner working on how to use mobile phones to help diagnose animals that are sick. There's a South African winner that's using vets and helping through digital. We've also run a very interesting youth summit where we had people from over 100 countries up to the age of 25 joining in, discussing AMR and what they thought should be the campaigns aimed at youth. And they voted, remember this is low and middle income, I do a lot of work for WASH, clean water and sanitation and hand washing. And so then they put in their proposals, and we've given 7 some seed funding, and they have just launched their programmes in schools around them, and we're about to launch another one on animal health. So we try all sorts of things, but it's only if you engage people and you get them to understand the importance that you can get change. And norms, as you will know, are terribly important.
I saw a hand, yeah, button.
We did a nice one, actually. When I was CMO, we found, worked out, we have the data nationally, on which 25% of GPs were the highest prescribers, We randomised them, and a letter went over my name saying, you're in the top 25% of prescribers, thought you'd like to know. I did get a pretty nasty postbag from You Don't Understand, and I had a standard, funnily enough, I might. But the use went down 13% over the next few months. It then came back up by the end of a year to 3% lower than it had started. But that was significant and was stayed. And the Australian CMO did the same. He copied it, the letter and everything, and got an even better result. But they were prescribing more. So there you are. You see, nudging can work.
So this is maybe follow-ups on some of the other questions asked earlier about the food supply. So when we think about AMR in other countries related to their food supply because of the global food chain, are there any ways that we can provide pressure on that to affect things? Like we already heard that we've lowered antibiotic usage in a lot of our agricultural sector. But do we have levers we can pull in other countries? Just also thinking about how this might affect things like protectionist trade policies and food, and how we might worry that AMR might impact that.
Very interesting. So the EU do a great job on AMR. I'm very supportive, and I'm off to see them next week again. But they have kind of made it a trade issue. They will not import meat into the EU where antibiotics have been used for growth promotion. The Americans don't like that. The Argentinians don't. The Paraguayans do. And the Americans find this dreadful because this is a trade war and you shouldn't put sanctions. And it is one of my worries that we may, to get a trade agreement for some other reason that we badly need, give in on this one. I mean, chlorine washings doesn't sound very nice, but it's not going to damage us. Whereas this, accepting growth promotion use, will damage us. Difficult.
Right, we've probably got about 10 minutes left questions. We've got two more distinguished Selwyn fellows on the front row. So Mike Tausig and then Colin Humphreys. So, yeah.
I was just coming back to this financial side. You haven't really mentioned what Big Pharma can do in this. Are they not interested compared with, say, cancer? Is it a low priority for them, or is it just not economically feasible?
It's about the economics. GSK are still working in this field and very worried about their share price and their profits. AstraZeneca got rid of antimicrobials. They want to free ride on everyone else, and I'm quite clear with Pascal Soriot that this is pretty poor show. So it is about the finances. They did, between them all, put £1 billion together to set up an AMR action fund that's working to try and pull through some drugs and things, and is doing some quite nice work. But the ones that are still in it, GSK, Pfizer, Merck, are really worried. If we don't get a good pull incentive, they think their shareholders will stop them working in this field, and we'll all suffer. Particularly us who are older, because the data is quite clear that AMR is going up in the over 70s more and more. Of course, you may not be, but I am over 70.
The cost of cancer drugs is usually, with the clinical trials, something like £500 million, isn't it? Is the cost similar for an antibiotic?
Yes, and it's possibly got more failures because you usually need to have a quite high level in the plasma in order to kill the bugs. So, yes, there's a quite high failure rate, lots of toxicities and things. So you think, oh, I've got the great drug, and then it turns out to be toxic. Right. But it can still be done. It's just you have to have the money.
Okay, Mike, if you want to pass to Professor Sir Colin Humphreys, who is...
No, thank you very much for really nice answers to questions. Can I come back to animals? So, I mean, the use is really, I think, very severe. So salmon farms nearly all do antibiotics, and trout farms and so on, fish farms. So how do you control this? I mean, you could say no more of these in the country if you're going to do this, for example.
Well, I went around the world a few years ago talking about the Norwegian salmon and trout farms because I'd visited them. I have a beautiful picture of me vaccinating them with a mixture of 3 vaccines, and they didn't need any antibiotics. And as you know, fish farming, fish protein is the biggest, steadiest rise in animal protein that's happening in the world at the moment. It turns out the Scottish salmon farmers are mainly owned by Norway, and they use the vaccines too, so they thought I was being very unpatriotic. The problem, they have lice, and they are making a lot of mess. The problem is not so much those, it's tilapia and sea bass and things, because what they do in the aquaculture is they just tip antibiotics into the water. And if you saw, which I have, the murky waters and filth, it's just horrible. So, yeah, it's real prophylaxis on a grand pond scale. And then, of course, it's in the water system because they flush these either tanks or ponds out into the water system and the water table. So it does worry me.
I'm trying to remember titles. I think Professor Grant Stewart, who is just there in the sewing tie, currently head of the Department of Surgery.
Yep, that's right.
Okay.
So actually, I've got a question about the general public. So just like the environmental crisis, it's important that individuals start doing things to make a difference. Can you give us 3 things that private citizens can do to try and improve this situation?
Well, the first is prevent infections, wash your hands. But then if you end up with a GP or in a hospital and the doctor says you don't need an antibiotic, behave and don't take one. Unlike the former Deputy Prime Minister who, as we all know, had a drawer full and said that she just handed them out to friends when they needed them because whenever she was given a prescription, she'd take a day or 2 if she felt like it. So training them on that, but also trying to get people to engage in why they don't need antibiotics and the importance of stewarding them and raising awareness and saying, oh, government, why are you not doing something? Because until we get that, it's very difficult.
And do you think we are close to having a much greater national campaign and international on this? Because I would suggest it's probably not at the level of awareness that we need in the general public, and possibly not in the medical profession as well, actually. But
correct. Yeah, this is where I say I failed. Perhaps I should go home and retire. Yeah, we have to find better ways of doing it. But as you know, it's terribly complex. I mean, the burden of disease studies are, I think, 76 bacteria and 30 antibiotics or something. I mean, this is the combinations and the complexity are so very difficult to explain to people that, yeah, we need a movement like climate change has. And it's equally complex. And as I keep pointing out, and the data's now there from modelling, it's going to kill more people by the end of the century than climate will. Yeah. I think people should be scared witless.
Yeah.
Okay.
I can imagine going to a doctor who says, Sally, you've got cancer. I can cure your cancer, but you're almost certain to get an infection, and you could well die of it.
Yeah.
It's happening in some countries.
Can I just sense check one thing from the film, which said that obviously you should try to avoid antibiotics unless you really need them, but if you take them, you should take the whole course? Is that true?
Yes, until we get the evidence for otherwise. And I did try some years ago, I thought up and set up the NIHR, and I did a call for people to do studies to see what the right length of course was, and we couldn't get any good applications. So at the moment, I would say take the course as you're given it, but I think there's a lot of research to be done, because it may well be that for quite a lot of these infections, if you feel well for 24 hours, that you could stop. But the evidence isn't there yet.
Okay. That's a very useful...
Is that right? I think that's right. Yeah, good. Just checking. And ITU, you know better than me.
Okay, that's a useful and I think practical point to end. So let me just do a quick plug, one of which is directly relevant. So West Streeting has agreed to come and do a session here, we hope next term. The one thing definitely fixed for next term is another of the Selwyn All-Stars. So Tim Davey, Director General of the BBC, is going to be here on Thursday the 6th of February, which I'm looking forward to very much indeed. And we hope you'll keep coming to our events and have a look at the website and the social media and check what we've got coming up. But Sally, can I thank you hugely for what I think was a tour de force tonight. So I don't know about everyone in the audience, but I certainly feel more safe and secure for the fact that you're doing this and leading the battle. So I know it can be tough at times, but thank you for the leadership you're showing as Special Envoy and what you've done in Cambridge as well to make everyone more aware. And obviously tonight was an important part of that. So thank you hugely. Thank you very much indeed.